Right, our next presenter is Dr. Dina Badawy. Dr. Dina Badawy is a teaching assistant, pathology teaching assistant at Faculty of Medicine, Luxor University, and pathology registrar at Shefa Al-Orman Hospital. Her presentation is entitled Fire Under Ashes, and it's supervised by Professor Dr. Shaima Al-Gohri, Associate Professor of Pathology at Faculty of Medicine, Ain Shams University.
Hello everyone, I'm Dr. Dina Badawy, a pathology resident at Shefa Al-Orman Hospital and a pathology teaching assistant at Luxor Faculty of Medicine. Today I'm presenting a case under supervision of Dr. Shaima Al-Gohri, Assistant Professor of Pathology at Ain Shams University. You are all welcome to our case today, Fire Under Ashes. Over the next 10 minutes, we will be diving into a challenging, exciting case highlighting the importance of thinking beyond the obvious. So I hope this case could offer new perspectives to all of us. Let's start our case. Female patient, 49 years old, presented with left hypochondrial pain and splenic lesion at Shefa Al-Orman Hospital. The patient was vitally stable. Her initial workup data were as following. CBC showed picture of anemia, INR was slightly elevated, serum tumor markers were elevated, high level of ESR, sputum and blood culture showed normal flora gross. About imaging, her CT abdomen showed soft tissue lesion seen encasing the splenic hilum and inseparable from the inferior pole of right kidney. Here is the mass and its relation with the spleen and the lower pole of right kidney. Actually, biopsy was postponed until correction of coagulation blood profile and blood transfusion was requested. Then, ultrasound guided biopsy was done. Grossly was multiple cores of grayish white tissue measured up to 1 to 0.5 cm long and it was all embedded. Sections examined revealed multiple tissue cores showing mixed infiltrate formed of plasma cells and Russell bodies together with small mature lymphocytes, many eosinophils, neutrophils, and histocytic cells with foamy cytoplasm in the background. Immunohistochemistry panel was ordered to confirm our provisional diagnosis, starting with CD138 and MAM1 highlighting plasma cells, CD68 highlighting histocytic cells, and Ki67 index was about 8%. Based on morphology and immunohistochemical markers, the diagnosis provisionally is dense mixed acute and chronic inflammatory infiltrate rich in plasma cells. But we have to stop here because our clinicians have another opinion. Another correlation needed with CT abdomen showed that the mass is inseparable from the pancreatic tail encasing the splenic hilum and it is unclearly separable from the anterior border of the lower pole of right kidney. It is measuring about 8.5 by 7 by 6.5 centimeter. Here is the CT, the mass and its relation with the spleen and lower pole of right kidney and pancreatic tail. So another biopsy was done as taking the clinician's opinion into consideration is a must. What could it be this time? Is it really an acute inflammation surrounding the spleen or it is something more aggressive? The second biopsy showed almost the same picture of mixed population of the inflammatory infiltrate of plasma cells, Russell bodies, and the histocytic cells with the foamy cytoplasm. Regarding the considering of clinician impression of neoplastic process within this inflammatory background, we planned for differential diagnosis as following. Lymphoma, classic Hodgkin lymphoma, histocytic sarcoma, myeloid sarcoma, carcinoma, or GIST. Immunohistochemistry was ordered to confirm one of these differential diagnoses started with CD20 highlighting scattered positive B cells, CD3 highlighting scattered T cells, CD30 was negative and it was no evidence of neoplastic RS cells, and CD15 highlighting scattered granulocytes. So, what we have is not classic Hodgkin lymphoma. Further, immunohistochemistry pancytokeratin was added and it was negative, so what we have is not carcinoma with inflammatory background. All those markers were negative: CD68, CD23, CD117, S100, and CD56. So what we have is not GIST or histocytic neoplasm. So what is the diagnosis? Do you think it is myeloid sarcoma? This is what we will cover in the upcoming slides. Started with MBO, positive in many granulocytes. As we can see in this shot, CD43 was moderately positive, CD23 and CD117 were negative. Correlation with further hematological examination was requested to confirm our provisional diagnosis of myeloid sarcoma. Bone marrow examination showed hypercellular marrow with reactive changes, including megakaryocytic and granulocytic hyperplasia along with mild dysplasia. There is no evidence of infiltration or non-hematobiotic cells in the bone marrow. So, there is no evidence of neoplastic infiltrate or non-hematobiotic metastatic deposit in the bone marrow, no suspicious lymph node, no abnormality detected in the blood picture other than anemia. After revision of Ki67 morphology, we found that it is not matching with the positivity of MBO and CD43. As we can see in this shot, Ki67 and its correlation of the result of MBO and CD43. So, myeloid sarcoma was also excluded, and what we have is not myeloid sarcoma. Actually, at first glance, we thought we were dealing with a straightforward issue, but soon things took a very unexpected turn. And we have a plot twisting here. Repeating Ki67 marker on the new biopsy revealed positivity, highlighting few large atypical cells. So back to the H&E sections to be correlated with the positivity of those large cells showed in Ki67. H&E sections showed scattered, non-aggregated, markedly polymorphic spindle and epithelioid cells showing high nuclear cytoplasmic ratio and prominent nucleoli. Now we are stuck with large polymorphic atypical cells with inflammatory background, negative to all the lineage markers, cytokeratin, LCA, CD68, and S100. Back to the previous immunopanel done to detect the negativity of those large cells to all the markers that we have done. MBO and CD43 are negative for the large cells. So what are those cells? We need to step back a little bit, and further immunohistochemistry panel should be added to confirm other sarcomas in an old patient with intra-abdominal mass. And now we can say that the clouds are gradually cleared. As we can see, CDK4 is positive in the large atypical cells. MDM2 was strong positive in the large cells, and B16 was strongly positive in large cells. I'm sure we now are sharing the same flying thoughts. To summarize up, T showing large mass has relation with splenic hilum, lower ball of right kidney and pancreatic tail. H&E showing large atypical polymorphic cells, positive for MDM2, CDK4, B16 and Ki67. Now we have gathered all the pieces of the puzzle, and yes, the diagnosis is finally here. Our diagnosis is dedifferentiated liposarcoma with inflammatory granulocytic and plasmacytic infiltrate myeloid-like. After that MDT, the surgeon was mass resection by splenectomy and distal pancreatectomy. This time we had evident lipomatous component showed abnormal adipocytes with enlarged irregular shaped hyperchromatic nuclei. These atypical fat cells have distinct cell borders and occasional multinucleation. So, about dedifferentiated liposarcoma mimics acute and chronic inflammatory process, or dedifferentiated liposarcoma with a background of acute and chronic inflammatory infiltrate. As mentioned in Inzenger and the Diagnostic Pathology of Soft Tissue Tumor textbooks, occasional cases of dedifferentiated liposarcoma shows a prominent neutrophilic dense lymphoid infiltrate, and it can be associated with leukomoid reaction. These findings may not be readily identifiable as liposarcoma. This finding is most frequently seen in the retroperitoneum. So detection of MDM2 and CDK4 overexpression or amplification can be very helpful. And it has been suggested that most of the cases called inflammatory undifferentiated polymorphic sarcoma are in fact dedifferentiated liposarcoma. And our take-home message for today: workup of the poorly differentiated or undifferentiated tumor remains a significant and challenging entity in the practice of anatomic pathology, particularly in the setting of small biopsies and limited material. The biopsy results are inconclusive and do not provide sufficient clarity for definitive diagnosis. Therefore, surgical resection is necessary to obtain more definitive diagnosis and to guide further management. This case highlighting the importance of balanced approach and collaboration that consider the patient's clinical and radiological presentation, a basic assessment of tumor morphology, and a reasonably broad immunohistochemical panel, what is called MDT collaboration. At the end, on behalf of the pathology department of Shefa Al-Orman Hospital, I would like to express many thanks to Dr. Shadi Elia. His insights were instrumental in helping us reach the correct diagnosis for this challenging case. Many thanks to Dr. Shayma Eggari for her significant role in the process of diagnosis, invaluable guidance, and making time for presentation despite her busy schedule. And of course, I want to take a moment to truly thank Dr. Muhammad Kamal, the head department of Shefa Al-Orman Hospital and the chief organizer of the day, for organizing such a really wonderful event. His efforts in putting everything together and the seamless execution is evident in every aspect of the event. I'm grateful for the opportunity to be part of it. Thank you and happy International Pathology Day.